right, everyone, we'll go ahead and get started on the second part of this chapter. It's chapter 28, soft tissue injuries. This part is exclusively dealing with burns. And so burns become very high yield, and I really I still do, hated these in like paramedic and EMT school because they're tested and you got to figure out this, like how much of the body surface area has been burned, do the rule of nines, and it's just annoying. And so, with that, they're tested. And so I can distinctly remember when I took my National Register EMT exam in high school, I was in high school. I was literally using the Palmer method, which we're going to talk about. Like your palm is 1% of your body surface area. Reading this question, trying to figure out how much of this patient was burned because I had forgotten the rule of nines. And so just keep that in mind that this is tested. I distinctly remember having this question on my national registry. And so we'll talk about how it's tested and what it looks like. And so let's go ahead and get started. So let me first say that burns are not as common as I would think. I can think of, uh, I don't know, living patients, like truly living patients, five that had like major burns. I can think of a few more that were dead, that were just burnt alive. And so they do happen, but they're not as common as I thought. But they're really weird. They're hard to see. They're hard to watch. They smell like burnt bacon. You know, like they just stink. It's painful. It's sad. It's disfiguring. So they do happen, but just keep that in mind. There can be a lot of overwhelming of the senses, I should say, because it's not only what you see, but you can feel the heat and you can smell the smoke or the burnt tissue. That if you've never smelled burnt human, it has a very or burnt hair has a very distinct smell. It's not like anything else you've probably ever smelled before, and so just keep that in mind. It can be overwhelming of the senses. And so, what is a burn? A burn occurs when a body part receives more thermal, electrical, or chemical or radiation than it can absorb without injury. Okay, and so the pathophysiology. Uh, these can be systemic injuries, meaning it involves multiple systems, right? Or it can damage cells and release vasoactive substances. That's one of the things you have to worry about in the hypovolemic shock that this can occur. And then the fluid shift from the intravascular space into the extravascular space will cause edema. Again, this leads to shock, namely like a distributive hypovolemic shock combo. And so you have to worry about that. Now, the pathophysiology continued. This will reduce. So again, the outside of the skin is the body's first line of defense, not just against organisms and other humans, but from the environment. So when you have a burn like this, right, you have a loss that portion of the body's ability to thermoregulate. So you have to worry about heat loss and hypothermia. And you're like, what? Hypothermia after a burn? They just got cooked. Well, it's because their body cannot regulate temperature in these areas because that part of the body has been injured. It's not working. So you do have to worry about hypothermia and burns, meaning low body temperature, because they will lose heat. Okay, hypovolemia decreases cardiac output, resulting in hypotension. Okay, and so they will lose fluid through this volume shift and also from weeping of the wound. And so the wound will lose fluid. It just weeps plasma, and so they can lose a lot of fluid this way. Okay, as the burn destroys skin, a tough leathery substance known as eschar is produced, and that's what they're describing here. You've seen burn victims probably on like TV shows, or that leathery skin appearance is called eschar. Okay, and it's spelt that way. Now, it's important. I do want you to know this, that the hypovolemic shock occurs for a variety of reasons, but because there's a loss of there's you straight up lose fluid from the skin. You can imagine that when you lose a layer of skin, you're going to weep fluid through that area, and so that would be fluid loss. And then so that is a form of hypovolemic shock. You lose volume. Okay, that would be the initial issue, and then what happens next is this fluid shift. Okay, where fluid goes intravascular to the extravascular space. And so you end up with a form of distributive shock as well, because you're distributing it to the wrong place for the edema. And so it's this mix of hypovolemic distributive shock, and you're like, wow, that sounds like a lot. Well, it is, and this is what's particularly difficult and fatal in burn management, is you have these fluid shifts and fluid losses that you have to worry about that create shock, okay? And so the coagulation disorders may cause blood to clot more easily, resulting in emboli. Remember, you can get blood clots. These blood clots can bust off, these cause thrombus, and then as they bust off, these create embolism, or emboli is the plural form of embolus. and they can launch off and go to the brain or the heart or the lungs or wherever. Okay. And then we can also get this condition that I've covered before in hematology called DIC, or disseminated intravascular coagulopathy. And so this is when you just start bleeding a lot because you've exhausted your body's blood clotting mechanisms. And so that's called DIC. And so the complications of burn is there's this huge risk of infection. Again, you've taken away the top layer of the skin, so you have to worry about that. Hypothermia, even though it's a burn, low body temperature. Hypovolemia, low volume within the blood, namely in the form of plasma, you'll lose. And all of this can result in shock. Okay, septic shock, hypovolemic shock, hypothermic shock. All of these are shock. Okay, now I'll show you some pictures later where you have to worry about complete airway obstruction, meaning if you burn this part of the body, okay, or you inhale superheated gas, you have to worry about this swelling, and it can swell so much it can swell completely shut. And so you have to worry about that with complete airway obstruction with burns. Very important. Compromised breathing, again, smoke is obviously toxic, and it can cause edema of the bronchioles and the lungs, and it's toxic. So compartment syndrome, this is another example. There's these things called circumferential burns, where if I circumferentially burn my arm, let's just say I dip it into hot boiling water for a minute and pull it out, right? I circumferentially burn my arm. And so what you have to worry about is as this area starts swelling around my arm, it will swell into these confined compartments. The fascia around the muscle will swell. And so you end up locking off these compartments and you can cut off blood supply. What is the hallmark of compartment syndrome? Pain that is out of proportion. Passive movement of the arm will cause pain that is out of proportion, meaning it's extreme pain for just simply moving their arm around. It's like excruciating pain. And so that's compartment syndrome. What is the treatment for this? It's called a fasciotomy. And so what we do is we go in there and we will cut the layers of fascia to open up those compartments. Who does this? Surgeons do this. Okay. Now, there's these things called the burn zones. Okay. And so this would make sense. It's intuitive, right? Where if I were to just take a cigarette lighter and hold it to this guy's arm precisely in this space for a long period of time, it's going to burn this area really bad. Okay, that's going to be the area of most damage. But as that heat spreads, it's going to also burn here and it could reach out here. Okay, it's called the zone of stasis. And so let's talk about what this is. And so the first area, the worst area, the most burnt area is called the zone of coagulation, because this is where the most amount of tissue damage occurs. And there's this thing called coagulation where the tissue itself coagulates, okay, and so it dies. And so this would be the most severely burnt area, okay? And as you go a little bit further, then you have the zone of stasis. And so this is the peripheral area surrounding the zone of coagulation. This area is also burnt and injured, but it's not as severe, okay? And then your last area is called the zone of hyperemia. Hyper means over, and emia means like blood. And so this is like the area that's least affected by the burn. And so you again, zone of coag, zone of stasis, zone of hyperemia. Okay, and so those are the order. So if you get lost, remember you start at the middle, CSH. Now, what's commonly tested is they'll describe a burn and say, well, what type of burn is this? So they'll say, like, for example, a first-degree burn, they'll say, lady fell asleep on the beach for 2 hours with no sunscreen. She was pale white before, now she is red, but there's no blistering noted, no blistering. And you would say, oh, that's a sunburn, that's a first-degree burn typically, okay? Now you can take it a step further and say, lady fell asleep on the beach for 8 hours. She has red skin, extreme pain, and blistering noted on the body. What type of burn is this? Well, that's a second-degree burn because you have now entered into the epidermal or to the dermis space. Okay, so it's bad, and so this is a partial thickness burn, also known as a second-degree burn. And then you would say, like, oh, okay, well, you know, some lady, I don't know, was caught in a house fire. I don't know, caught in a burning car, and she has, you know, completely dead tissue. It's black, it's burnt, it has no sensation. That's a third-degree burn. And so we'll talk about what these are, but basically what we're looking at is how far did this penetrate, and that classifies the burn as the penetration. And so obviously the higher the temperature and the more or the more longer you're exposed to an extreme temperature, the further it's going to burn you. And so, the classic example of a first degree burn is a sunburn. We've all had a sunburn. And so this is also known as a superficial burn or a first degree burn. This is the outermost layer, the epidermal layer gets damaged. Okay. And then the next one is a partial thickness or secondary burn. This is where you'll see blistering, but it is still painful. Okay. And then the last one is a full thickness burn. It will not be painful in the exact area, okay, because it has been destroyed. All the tissues in there have been burnt and destroyed, okay? And so let me show this to you an example. Let me just show you something. Let's take the same example. I take my cigarette lighter and I put it up to this arm right and I just burn for like a minute, okay, or however long. This area right here, let's imagine this is the 3rd degree burn, okay? This is the 3rd degree burn. So if you were to take your pencil and touch right here on the patient, they will not feel anything, okay? Because their nerves have been burnt, okay? There is no sensation there. But that does not mean that right here on the 2nd degree burn is, and this is probably second here, is going to hurt like crazy because that 2nd degree burns hurt. And then you might, if it got far enough, have a 1st degree burn here, okay? And so this is like, I'm showing you the whole stasis, coagulation, hyperemia. That is what this picture is describing, but that's where I think students get lost thinking like you can only have a 3rd degree burn. Well, no, what I'm saying is you could have a 3rd degree burn surrounded by a 2nd degree burn with a little layer of a 1st degree burn on the outer layer, or just a 3rd and a 2nd degree burn. Or if it's directed energy, you could have a straight up 3rd degree burn with no surrounding tissue damage. But what's most common is you get like a 3rd degree burn with 2nd degree burns around it. Okay, so just watch out for that. Because what happens is students hear like, whoa, if it's a 3rd degree burn, it doesn't hurt. Well, that area of the burn doesn't hurt because the tissues have been burnt off. And so, or the nerves have been burnt off. And so they're dead. So they're not carrying the message back to the brain to say, ouch, that hurts. And so that's something to think about. And these are pictures of respective burns. So I'd ask you, Studente, ¿qué está aquí? What is this here, right? And it's a 1st degree burn. We've all been here. Welcome to Texas. Welcome to Mexico, right? So this is a 1st degree burn. There is no blistering. It is red. It is hot. It is warm to the touch. It is painful, right? That is a 1st degree burn. And you'd say, well, what is this? So first, this is a 2nd degree burn. And so you see blistering, right? Blistering. So this has affected the dermal layer, okay? The other word for a 2nd degree burn is a partial thickness burn. These are bad. And so, yes, you could get this from a long enough sunburn, but this is more likely like, you might see a vignette, they poured hot boiling water on themselves on accident, or, grease popped onto them or something like that. They grabbed a hot pan of cookies, I don't know. So just something like that, okay? Now, this is a 3rd degree burn. So this area, I mean, they have obviously, their tissue is cooked, right? And so this is a 3rd degree burn. And so what I was trying to show you earlier is like, yes, this is obviously a 3rd degree burn here, but do you think that this could maybe be a 2nd degree burn here, or here, or here? Probably, possibly. And so that's what I'm trying to point out, that yes, if you were to touch right here, the patient's not going to feel that because it has been burnt that bad. The nerves have been burnt off. But here, they are going to feel that. So they would have pain outside of the burn usually. Now, there's several factors to a burn. The depth of the burn obviously makes sense. That's how we classify them. But the extent of the burn. Okay, I have a friend who this last summer he sat on a forklift and he was raised like 30 feet up in the air. It's like 110 degrees outside. And at first, it was just a little warm. But as he gets about 20 feet in the air, it is burning his butt. And so he ended up with 2nd degree burns in a straight line across his butt cheeks because he sat on something that's fairly hot for a long period of time. And so that's something to think about, that the amount of, it's not just heat that affects a burn. It is how hot it is over how long of a period of time. Okay, so that's something to keep in mind. And so obviously the critical areas involved, burn areas are going to be the face, circumferential burns, burns to the peritoneum or to the genitalia, right? So if you get a burn on your penis, that is extreme. That is a bad deal because you have to worry about tissue damage. And so just look for those. Those would be extreme burns, okay? Critical burns. Pre-existing medical conditions, so a diabetic, someone who has peripheral vascular disease, someone who is old or very young. These make burns more critical as well. Something to look for. Now, the whole burn scoring system, it's called the rule of nines. Excuse me. So the body's divided into 11 sections. And if you add all these up, it'll equal 100. Okay. And so we can get to what's called, this word's called the total body surface area that is burnt. Okay. And so the TBSA is how we predict this. And so that's the rule of nines. I'm going to show you a picture, and then I'll come back to the rule of palms. And so this is the rule of nines. And so this says that the whole head is 9%, each arm is 9%, each leg is 18%, the front torso is 18%, the chest and the abdomen, and the whole back is another 18%. And if you don't believe me, you can check it. That equals 99. And the 1% is the genitalia. Why is that? A palm should roughly cover the genitalia area. And so, at least the general area. And so that's the rule of nines. And I make it sound really simple, but it gets harder than that, because what they will do, and we'll practice this in class, is they will say, oh, the patient has burns to their face and to their chest. And they're like, oh yeah, that's 9 and 18, that's 27. That's wrong. It's 4.5, because it's only half the head. It's 4.5 is just the face, right? That's where it's complicated. And the chest is just this area. So that's 9. So they're really burnt on like 13.5%. And so, this is where it gets really annoying. Or they'll say that, and this is where medical terminology becomes important. They'll be like, oh, the patient has, burns to the anterior portion of both arms. And you're like, oh, both arms? Okay, and you'll calculate that. But it's only the interior portion is just the front portion of the arm. That's just this area here. So that's 4.5 plus 4.5, right? That's 9. So they're burnt on 9% of their body. And so this is where it gets complicated and annoying and really kind of arduous to calculate these. And again, they use medical terminology. They'll say like, oh, they have interior burns, or they could say, oh, they have circumferential burns distal to the elbow. So you'd be like, oh, what's distal to the elbow? That's this whole area here. And if it's circumferential, it's all the way around. So that would be 4.5%. See where I'm getting at with this? It gets complicated. It's very annoying. Now, that's an adult. So what am I saying? You 1000% need to know this. Get a tattoo of it. I don't care. You need to know this. This will get tested. I promise. You will get tested on this. Okay, and they will throw you a vignette, describe where this patient's been burnt. You're going to figure out what's their TBSA, how much has been burnt. Okay, and so that's how that works. Now, moving to the Nino over here, the little boy, it becomes a little different. And that the reason for this is babies' heads are about a third of their height. Okay, so a baby's head is very big in relation to their height. This drawing doesn't do a good job showing you that, but take my word, babies have really big heads in proportion to the rest of their body. So what do? We rob a little bit of TBSA from their legs and we shove it up to their head. And so what we did is we stole 4.5% from each leg, okay, which equals 9, and we put it up in their head. And so their head is now 18%, okay? And the child is somewhere in between to where their head's just 12%. So we borrowed 2.5% from each leg. And so, 1.5% from each leg. And so that's just a general rule. So where am I? So I don't want to confuse you with this, but screenshot this, do whatever you got to do. I promise you're going to get questions on this. Okay, I'm writing your exams. You're going to get questions on this. So it's coming. Okay, you're going to have to calculate total body surface area. They test this on the National Registry. It's low-hanging fruit once you get it down, but you will get tested on this. Okay, now I will say typically vignettes won't be like, oh, is it 35 or 36% burn? They won't do that. The answer choices aren't going to be like stacked on top of each other. So again, a lot of times you can get into a ballpark using this and find the most correct answer. So watch out for that on test, to where you'll be like, well, I mean, I followed Hunter's rule of nines and it equals 36, but they only have the answer choices are 12, 22, 25, and 38. Well, you need to pick 38. That's the closest one to the 36. Does that make sense? So watch for that. That really pisses students off to where they're like, it's 36%. Well, remember, this is an estimate, okay? It's not the actual percentage. And so we pick the one that's closest to the number that we calculated, okay? Now, what is the Palmer method or the palm method? What this says is the patient's palm, not your palm, the patient's palm is 1% of their total body surface area. So, in burns covering less than 10% of the body surface area or that are irregularly shaped, you could use the patient's palm to predict how much has been burnt. That's what the Palmer method is. Now, why is this important? Okay, when you take the National Registry or even your exam in class, I can't take your palms away from you. So, if you get lost in the sauce, you can sit there and start palming yourself to figure out how many palms can you fit on your abdomen. It's probably close to 18. So that's where this comes into play. Now, assessment of burns determine if there's any more serious injuries. You really have to worry about airway. We'll talk about that. Classify the burn to determine its severity. Okay, usually you can figure this out based off of a few descriptors, like blisters or redness or pain, or, is from the sun versus is from, boiling or hot grease or whatever, gasoline, whatever you come up with. Determine the scene size up. Remember, scene safety is paramount in this. I see all the times firefighters. Remember, you're not a firefighter on these exams. Turn it off. You're an AMR, care flight, whatever you want to pick, medic, MedStar medic, EMT. And so you cannot be firefighter when you answer these questions. You are not running into buildings and helping people. You are an EMT only with no fire training. Okay, so determine the type of burn that has been sustained and the mechanism of injury. Assess the scene for any environmental hazards. Okay, your safety first. Consider the potential for spinal injuries, inhalation injuries, and other injuries like toxic inhalation, carbon monoxide, cyanide. We'll talk about that. Okay. Perform your rapid survey. It's the rapid full body scan, right? Use simple clues to identify the severity of injuries, like, oh my God, every bit of their clothing has been burnt off at them and is now stuck to them, right? It's a serious burn. Use your clues. They were stuck in a car that was burning for 10 minutes or whatever. I don't know. And so be suspicious of clues that may indicate abuse. Signs that indicate abuse with burns is cigarette burns. Okay, you'll see this in children quite unfortunately, where they will get burnt with a cigarette. So if you see like a perfectly round burn that's about the size of a cigarette, that's abuse. Okay, so those people that are abusing them should be reported and hung from the highest tree. And consider manual spinal stabilization. And then check for responsiveness using AFPU. Remember, alert, verbal, pain, unresponsive. We use this to determine if the patient's alert or what level it takes to gather a response from them. And then look for signs of airway involvement. So signs of stridor, wheezing, hoarseness of voice, difficulty swallowing, difficulty breathing, mouth swelling, tongue swelling, airway swelling, tissue swelling, burns of the mouth, face, or trachea, nose, or throat. These are all things you would look for. Inspect and palpate the chest wall for DCAT, BTLS, deformities, contusions, abrasions, punctures, burns, tenderness, lacerations. Oh my God, why can't I remember? Oh, swelling. Assess the pulse rate and quality. Now, this is where history becomes important. We got to figure out, like, I poured boiling water. Okay, well, is it actually boiling? Yes, it was actually boiling, or is about to boil, or what was in the boiling water? Okay, was it tea? Was it grease? Like oil, like canola oil? Like, what was it? Signs of a burn are obviously going to be redness, swelling, blisters, and charring. Symptoms include pain and or burning at the injury site. Obtain a sample history, and you would ask the necessary questions. Now, so we would use the rule of nines to estimate the burn, and so this is where we start looking for, again, airway burns. What you'll typically see on an exam is these hallmark signs. They'll spoon feed you these, and so if you see these phrases in a vignette, you need to be thinking like, oh, that's an airway burn. So soot, meaning like the black stuff around the nose or the mouth. That means they were breathing in something hot and the soot had stopped here. So you would assume that's also inside their nose and their trachea and their lungs. So that's an airway burn, okay, until proven otherwise. Also singed nasal hairs, okay? So you have hairs in your nose, or you're supposed to. And so if you can tell, like, oh, those are burnt, that was hot enough to burn the hairs. It was certainly hot enough to burn the soft tissue. That's an airway burn until proven otherwise, okay? It's a life-threatening emergency. Listen for breath sounds. What sounds will you hear with a burn? When you use your handy-dandy stethoscope, it's going to be stridor. Remember, stridor is the sound. It sounds like this. It's on inhalation. You see what I do for you? I make these crazy noises. It's a high-pitched noise on inhalation. It indicates upper airway swelling. Okay, you see this in foreign body airway obstructions, croup, all right, a viral infection in children, and you also see this in burns. Now, you could also hear wheezing if they have like reactive airway disease, or if it had reached their airways to cause obstruction. Okay, so but stridor is a hallmark sound you will hear with upper airway burns or with like burns in general. Stridor. Okay, that is a high pitched noise on inspiration. Assess the patient's neurological system, assess their musculoskeletal system, obtain vital signs, use monitoring devices. That's intuitive, right? And then you're going to reassess these patients. So a lot of times these patients, depending on the severity of the burn, will need to be transported to a burn center. So that might involve Parkland or Medical City Plano. If you're in the Dallas-Fort Worth area, those are the two top burn centers. Someone told me that John Peter Smith has upped their burn game, but I don't think they're fully classified as a burn center, to my knowledge. If they are, I'm sorry, I don't know. Now let me give you an example. If someone burnt their finger grabbing a tray of cookies and they burnt their two fingers, they can go to Medical City Weatherford or really to any hospital. That usually doesn't require a burn center. It's when we have major burns where those patients need to go to a burn center and you may consider flying them, okay? Because they're usually further away. There's not very many of them, so like it's worth flying a burn patient from Weatherford to Plano. It's a long way by ambulance by ground, okay? Provide the hospital personnel with a description of how the burn has occurred, right? The area that's been burned and the specific areas are involved. So, example, if the face is burnt, if it's circumferentially burnt, if the genitalia is burnt, if a large a total body surface area has been burnt, if they're very young or very old, these are all things that can classify as a critical burn. For EMT school, you really don't have to know how to classify a critical burn. For paramedic school, you do. And so these are all things that you're wanting to gather to be a good EMT. Now, the management, right, the goals are to stop the burning process. 1, to assess and treat breathing. 2, support circulation and provide rapid transport. Okay? And so you have to think, like if someone obviously was in a car wreck and they got burnt, you have to still consider spinal motion restriction. Or if someone was found, in a house fire on the ground and they were burnt, you might have to suspect that they fall. So spinal motion restriction is still usually indicated in burns, okay? If the patient has signs of hyperperfusion, you're going to aggressively treat the shock. For us, that's going to be, keeping them warm, keeping them, paramedics would give them IV fluids, and then you could elevate the lower extremities, rapid transport to a hospital, providing oxygen is indicated, right? Treating shock aggressively. Cover all burns according to a local protocol. Typically, we cover burns with a moist sterile dressing. You don't typically want to use a dry sterile dressing because it will stick to the wound. And so when you pull that off, it's going to take the tissue with it. It's not catastrophic if you do, and there's different trains of thoughts. Some places will say to use a dry sterile dressing. I'm not, that's between you and them, but just know it varies, okay? So this might be a scenario where you request ALS intercept or a helicopter because the IV fluids can be very helpful in burns because of, remember, the hypovolemic issue that can occur with critical burns. Okay. Now, thermal burn, these are going to be your most common burns. Thermal means like from heat. Okay, it's a flame burn. Is often a deep injury. So this this could be a scalding injury from a hot liquid, like pouring boiling water or hot coffee on yourself. A contact burn would be like touching like a hot cookie sheet. Okay, I keep using that example because we all have done it. A steam burn, these are exceptionally painful, and because the steam burns so well because the way the water will coat your skin, so it's called a scalding burn as well. But these are exceptional burns. A steam burn. Flash burns are produced by an explosion. So, like when a bomb goes off, it can, depending on the bomb, produce superheated, like a flame that is very, very hot and intense, but it's very quick. And so it's a flash burn because it whoosh. And so it's very intensely hot, but it's over a short duration of time. And so that's why we call those flash burns. You typically see those with explosions. Now, back to inhalation burns. If you see this guy, you're thinking, oh my God, he's about to die if we don't do something because he has airway burns. And so, this is what the normal lungs would look like, right? This is the carina. But this, you can tell an increased severity of burns. Like, oh wow, like that literally looks burnt. Okay, and it swells. You see, it's very swollen here compared to here. These nice open chambers. This is swollen. Okay, and so you have to worry about this eventually swelling shut. Okay, what noises will this make when you listen to the stethoscope? At first, stridor and high-pitched sound on inspiration as you breathe in, stridor, and wheezing. Okay, wheezing is a sign of obstruction, so you see this with asthma. You can also see this like with like reactive airway disease from smoke. Now, most deaths from fire are caused from inhalation of toxic gases, upper airway compromise, or pulmonary injury. And so this is something to be aware of. And I've mentioned this before. You would think like, oh, someone in a house fire, what did they die from first? Was it the flame itself, like cooking them alive, or was it the gas, usually the gas, or was it their airway swelling shut? Maybe probably that second, or pulmonary injury. You know, those go hand in hand. And so keep that in mind. It's usually, I would say the toxic gas, especially in this scenario, especially in like a house fire or car fire, is by far the most common way they'll die first. Okay. Infection prevention is important. So again, you know, irrigation could be helpful to where if they're like covered, like say they lit a campfire on fire and they started to stop, drop, and roll in cow poop or whatever and dirt, you know, you might irrigate them with some saline to A, stop the burning, and then to B, to get the stuff off if possible. Okay. Carbon monoxide intoxication, we've covered this in toxicology, but notice it showed up again. What does that mean? It means it's high yield. It means you need to know this, okay? So carbon monoxide intoxication occurs when it's the byproduct of combustion of material. And so this is a clearless, odorless, tasteless gas. You know, it's commonly wrote as CO, okay, CO. And so what you'll get is you have to be suspicious when your pulse oximeter reading is very high. Remember, carbon monoxide has a very high affinity to bind to hemoglobin, much higher than oxygen. So it will bind to the hemoglobin. And remember, pulse oximetry just measures how saturated is hemoglobin with something. That something is usually oxygen, but after exposure to carbon monoxide, it was also very, very elevated. So 99 to 100%. They could have a bright cherry red appearance, a high pulse oximetry reading, alter mental status because their hemoglobin is bound with carbon monoxide, not oxygen. Okay, these are all things to look for. Okay, very fatal. The patient will die of hypoxia, hypoxemia. Okay. Now, important thing to remember is anytime you have a group of people in the place reporting headache or nausea, you need to think this is either one of two things. It is food poisoning, one, or two, it is carbon monoxide poisoning. Okay, so watch for that in the vignette. You have a household of 8 at Christmas time that are all complaining of headache and nausea. You're thinking they ate some bad deviled eggs or they have been exposed to carbon monoxide. So, you know, consider that. Now, hydrogen cyanide is the byproduct of combustion of inorganic materials. So what do you see this in? This is like in like carpet, upholstery, cushioning, you know, anything inside a car is obviously not organic, man-made. And so this is where you see that. Now, remember, cyanide turns off the electron transport chain that creates ATP, the energy currency in our body. And so when you turn that off very abruptly, you die very abruptly. So this is a very effective poison that is actually used occasionally in assassination attempts successfully. And so just keep that in mind. It's a gas. They say it can taste like almonds or it can smell like almonds. But if you're in a house fire, you're not going to be smelling almonds. You're going to be smelling smoke. So there is a treatment for this, but it's paramedics give it. It's actually vitamin B12 that's given IV or methylene blue. There's two. And so anyways, the signs and symptoms of this are what you would think what they would sound like, where your body just turning off. You're going into shock, faintness, anxiety, abnormal vital signs, headache, seizures, paralysis, coma, death, right? Those are the signs and symptoms. So watch for that when someone has been exposed to like inorganic material that is burned, like a couch on fire or something like that. Chemical burn again. This time it's to the eye. So how would we treat this? Like this. You take an IV bag and you just spike it. We've shown you how to do that in class by now. And you just let it drip up onto the patient's eye from the nose out this way. So you'll have the patient turn their head to where it'll just drip across the eye and off the face. Okay? And so, you know, you can get a chemical burn to the eye, and so the eyes are particularly vulnerable because they're, you know, what I tell you, the thinnest layer of skin in the human body is the eyelid. So when you burn this, it's particularly bad. Okay? So severity of a chemical burn is related to several things. First off is the pH. Whether it's very high, meaning it's alkalotic, okay, or like lye is alkalotic, or it's very low, it's very acidic, okay. Both can cause chemical burns. the length of the time that the patient was exposed. So again, it's on there for a minute versus 2 hours. It's going to change the level of burn. That's intuitive. And the volume and physical form of the agent, right? So was it a little bit of something that got on them, or was it a gallon of it that got on them, right? These all determine the severity of it. And again, this is all intuitive. So sometimes I feel like a fool explaining these to you. But the treatment can be specific to the chemical agent. One thing I'll say, the universal way to treat chemical burn is to brush it off and then to irrigate it with water and or saline. That is the most common way to treat this. Now, in industrial incidents, they have what's called the MSDS, Material Safety Data Sheets. Okay, it's a book that has like all their materials in it to where it has specific antidotes and protocols if you're exposed to them. Okay. You could also call medical control or even the poison control hotline sometimes if you need help on that. Now, this is what we do first. At first, we brush it off in chemical burns, and then you irrigate it. So if they tell you, patient works at a factory, they feel like they've been burned, there's a white powdery substance on them, what do you do first? Maybe not you, but someone would brush it away first, and then, irrigate them with copious amounts of water. That is the treatment, in that order. So again, like dry lime, remove the patient's clothing, brush it off, and flush with copious amounts of water, okay? Sodium metals, this is ridiculously stupid that they test you on this. Okay, if you don't know, sodium is very explosive, like straight up Na sodium, which is it's not found in nature this way, right? It's only man-made. It explodes, like literally like a grenade explodes. And so if somehow some goober got straight up sodium on themselves, you would want to cover it in oil. Why is that? Because sodium reacts with water and air, like oxygen, the ambient air and water. So this is crazy. If someone has sodium on their skin, straight up sodium, Na, and you pour water on it, it would explode more. So just keep that in mind. Hydrofluoric acid, again, you don't carry this on the ambulance, but you could do calcium gluconate gel. Gasoline or diesel fuel, you can remove this very effectively with soap and water. If they haven't been burnt, like they just had gasoline or diesel spilt onto them. In fact, I'll go a step further. What is very, very effective is like Dawn dish soap. It has a degreasing agent that is soft enough on skin to not harm you, and so it is extremely effective at removing petroleum. Okay, hot tar, again, you would immerse the affected area in cold water. Okay, irrigation. So this is what I was showing you. Now, there is another way, I think I've showed you this before, where you can take a nasal cannula and drip water through it, and to where you can have a cannula on the bridge of each nose and allow water to drip both ways across a patient's face. That is a way to treat these types of burns as well. Now, electrical burns. These are very bad. Let me tell you a few general rules of electrical. Volts don't kill you. It's amps that kill you. So know that. Volts don't kill you, it's amps that kill you. Amperage is what kills you. And so voltage is simply the push of electricity. So how hard are you pushing electricity? And so a taser, you may have heard like, oh, the taser's 1,000,000 volts. And what it's doing is it's pushing a small amount of electricity really, really hard. And so it hurts. And so you get pain compliance, right? And so that's one way that works. Now, if someone were to like be building a house and they grab the main wire to a house or a power line outside, it has an incredible amount of amperage moving through it. Fairly low voltage, but tremendous amount of amperage. And so that will cook you. I mean, it'll burn you. It'll kill you so quickly. And so what happens is you get an entrance and an exit wound, okay? And so what the entrance wound is smaller, just like in a bullet, the entrance wound is smaller and the exit wound is larger, and that's demonstrated here. So if you grab here, that electricity will travel through your body and ground itself and shoot out in a larger area. And so of these two, I would ask you, student, which one looks more like an entrance wound and which one looks more like an exit wound? And you would say, well, this looks like an entrance wound and this looks more like an exit wound, salida, right? And so that is the difference between the two. And so just keep that in mind. That's occasionally tested. So you'll see an entrance wound on the hand and it exited on the foot. So that means electricity, when they grab that wire, went all the way through their body and got bigger, bigger, bigger in that pattern I just showed you, and it'll blow out at the bottom part. Now, depending on electricity, this can blow extremities off. You can get amputations. And so just be aware and think everything in the pathway that that electricity is traveling is being burnt internally and externally. So this is, I mean, electrical burns are very critical, like obviously very fatal because you're cooking the inside of the body and all the tissue that it's traveling through, depending on the amount of electricity. And so that's something to be aware. So, large amount of deep tissue injury. Again, these are internal injuries. You might see some external burning as well. It's called ferning is the word, ferning, Ferning. But it is burning inside of their body like really bad. Okay. Cardiac or respiratory arrest from an electrical shock. When you shoot electricity across the heart, like everyone clear, right? Like in the movies, defibrillation is what it's called. You jack with the electrical cycle of the heart. And so when someone is struck by lightning or they grab a high amount of amperage, you can stop the heart or throw it into this chaotic rhythm and they will die. And so CPR is usually indicated. In fact, I'll throw you a little nugget. When we talk about triage, I don't want to, yeah, I'll tell you. In triage, if someone's been struck by lightning, it's the one time and they're dead, you can start CPR because there's a high chance you'll get them back if you start CPR early enough. So that's just something to know. But anyways, you'll look for signs of hypoperfusion. The problem with internal burn, like an electrical burn, really all major burns, but especially like electrical burns, is you have to worry about the damage to the kidneys because as this tissue breaks down, especially the muscles, it causes damage to the kidneys, or this itself will zap the kidneys and burn them. And so these are really bad. Electrical burns are awful, incredibly fatal, if not immediately after the fact. Very hard to recover. So just be careful around electricity. I'll share with you a very scary, probably the second closest, maybe if not the single most closest time I ever came to dying as a paramedic. This is an important story. I don't share a lot of war stories, but basically it was on Zion Hill. This guy, it was like 5 in the morning, right, on his way to work, middle-aged man. He hit a tree going very fast, but it was on like a kind of a somewhat residential road, but it was in the country, right? And so he hit a tree. It's raining. We get there, and he's just screaming in pain. He's entrapped. His door got ripped off, so I can see him. So I go to the other side of the vehicle, and I'm like assessing him, right? And I keep thinking, like, I keep tripping. Like, as I'm moving around, I keep tripping. And I thought it was vines. It was the electrical lines and the cable lines were down. He had hit a telephone pole that had snapped, and then he had hit the tree. And since it's dark and it's raining, and I'm focusing on the screaming guy whose femurs are shattered in his vehicle, covered in blood, and I want to help him, I did not realize I was stepping on electrical lines. Thank God it had tripped itself and turned off. Had it not, 1000% I was getting lit up, right? I probably would have killed me because I was so wrapped up in it. And so it would have been hard to escape, right? It's between the vehicle and a fence, and there's electrical lines down in the ditch that I'm standing in. And so where I'm getting at with this is a scenario of I try to be really cognizant and have good situational awareness. I got trapped into, there's a screaming guy over there in the car. I want to help him. His door's been ripped off. I can see him. I can help him. And I did not realize I was stepping on electrical lines. And so that would have killed me. And so, or severely injured me. Certainly would have changed my life. And so be careful with that. Again, our safety first. Okay. Once we determined there was lines on the ground, we had the fire department make sure that it was turned off. And then they had moved the lines to the other side of the fence to where we were no longer stepping on them and they were not a hazard. Okay. Just keep that in mind. You'll see that in vignettes. Now, last couple slides, determine whether there's an ongoing exposure exists. So there's these things called, or there's this thing called ionizing radiation that comes in different forms. And your book has a picture that I meant to put on here that talks about alpha, beta, and gamma. So you can know alpha is like the sun, and beta would be like cell phone towers, and gamma is like nuclear radiation. And so they pierce deeper. So you could deflect the radiation from the sun with a piece of paper. You could deflect beta radiation with maybe like the walls of a house. And then gamma radiation, you cannot deflect that. That's like X-rays, nuclear radiation. And so these get increasing severity and penetration availability. And so you should know radiation in any of its forms is bad, but especially beta gamma radiation, especially gamma radiation, you have to worry about radiation injury. And so, what I just described of the radiation is a direct exposure, right? Like you're being directly exposed to this. But you could also potentially inhale radioactive dust from like a nuclear bomb that is left off. It's called nuclear fallout, right? And so as the bomb explodes, it leaves this nuclear dust. And so when you inhale that or you ingest it or it touch your skin, you can get radiation sickness, which is what this talks about here. And so this can be remarkably fatal. And unfortunately, this is what they call a dirty bomb. The two times that we know this has been used in war in Japan, the blast itself could kill a tremendous amount of people, as horrific as it is. But the radioactive fallout from these bombs killed, I think it killed quite a bit more. I don't know that for a fact, but it certainly killed, again, a tremendous amount of Japanese people. And so this is one of the remarkable effects of nuclear bombs or dirty bombs that carry radioactive material in it is you got to worry about radiation sickness. Now, where else do you more commonly, since that hasn't happened in since the 40s, do you have to worry about this? Is like nuclear power plants, right? If you have like a meltdown or you have release of that into the atmosphere, same thing with like X-rays or nuclear medicine. Like these are all exposures to radiation that you could be aware of. Okay. Now, of course, as we always say, your safety first. If not properly trained, maintain a safe distance and wait for the hazmat team to decon the patient before initiating care. Again, firefighters, turn it off. Someone with that specific training more than likely would need to come decon them. Okay, so that's it with burns. A few things that I really want to stress for you. I know I burned through that quickly, but don't underestimate the importance of this chapter. With there's two things you need to like have burnt into your skull. Get it? The layers of the burns and how they present. Okay, superficial first degree burns, what do they look like? How do they present? Second degree partial thickness burns, what do they look like? How do they present? Okay, and a full thickness burn, what do they look like? How do they present? And then the rule of nines. You absolutely will get tested on both of those. So do know those two things exceptionally well. Uh, and so, like I said, we'll practice this in class. We'll throw some problems up on the board. We'll run some scenarios where I'm going to sit there and be like, what's the total body surface area burnt? And you're gonna be like, oh, it's 36%. I'm like, okay, well, there's blistering here and there's not blistering here. And so what type of burns are these? And so we'll have to figure those out in class, but we'll get exposure to this to hopefully make it better and more helpful for you. Okay. And with that, that's all I have for this chapter. I appreciate y'all's attention.